Paul, welcome. We were just finishing up with Belinda, another fellow Australian. I don't know if you guys have you guys met each other before?
Yes.
Okay, cool. All right. So has warmed up the audience for you, and I'm not to diminish what you know. We've had a great conversation, and Belinda, thank you so much for coming on. I think if it's okay, we'll just continue and just roll straight into Paul. Paul, I talked to the other day on our podcast, but he's always a wealth of knowledge. I think we can talk about almost any and all topics related to human health and carnivore and whatever. But I mean, Belinda, you're welcome to stay if you want and listen. We're going to give Paul a chance to talk now. So Paul, if you don't mind, I'm going to grab a glass of water. If you don't mind introducing yourself to the crowd. And the way it works is we have questions that people can ask. I'm going to mute everybody and then I will be able to, just read their questions as needed, and we can kind of start chatting a little bit. So I'm gonna, let me see, mute everybody, and you guys get ready to type your questions. Paul's got a lot of, he's a doctor that sees patients, and you guys that have medical issues, he can probably help you with. Belinda, thank you so much. You're free to stay and comment and harass Paul. Paul needs harassment, believe me. And I'll be back. You got Paul introduced us. I'm gonna grab some water. I'll be right back. Paul muted. I guess if I unmute you, it would make life a lot easier. I apologize. Sorry, guys. Go ahead, Paul. If you want to do a quick intro, and then we'll get into the meat of the matter.
So we had a couple of little technical issues there, no problem. So good morning, and good morning, Belinda. Always a pleasure to see you. My name's Dr. Paul Mason. I'm from Sydney in Australia. I'm a sports and exercise medicine physician, and I have a special interest in nutritional medicine, particularly ketogenic, low carbohydrate, and animal-based diets.
Perfect. And Paul has been doing this for at least a couple of years now. I've met Paul personally a few times, really good guy. We've had a lot of discussions back and forth, and Paul's got a lot of great insight and a lot of clinical hard data, which I think at the end of the day is what we all really, care about. So I want to just, we talked about sports. I think sports is a major topic of concern on today's crowd. So let's get into health a little bit. I want to talk about, let's talk about weight loss, insulin resistance, and, type 2 diabetes, because that is such a common problem, and whether people are on that spectrum. Like I kind of consider diabetes as, it's that spectrum of insulin resistance. What are your thoughts on what are your thoughts on the cause of insulin resistance? It's multifactorial, but what do you think the major things most people are dealing with?
Well, essentially, we can either talk about the mechanisms or we can talk about the practicalities of what people do. And I think the practicalities of what people do, it comes down to two things. It comes down to carbohydrate excess, and it comes down to oxidized oil intake. Both of these things, so excess carbohydrates have been shown to lead to increased fat production in the liver, a process called de novo lipogenesis, which has been directly associated with insulin resistance through various mechanisms. And we know that oxidized oil consumption has also been shown to lead directly to liver damage in and of itself, which is also associated with insulin resistance. So for most people, just getting your carbs down and avoiding oxidized oil consumption, insulin resistance will improve dramatically and predictably. And we see this in our patients. So you're familiar with the Kraft test, Sean. And when we do the Kraft test between, 3 months after somebody started a healthy diet, we see massive reductions in serum insulin levels, all the while we're still having improved glycemic control.
Can we eat too much saturated fat? Is that a possibility? If we just sit there and pound ribeye after ribeye and we eat it in excess of what we need, is that possible to cause, because I know there's a big concern about intracellular lipid deposition in the form of things like ceramides. And so can we get into trouble in that regard?
So there's a couple of key points here. So first of all, let's go to the PURE study, which actually was a prospective study looking at all-cause mortality based on dietary consumption. And the interesting thing there is that they did an analysis of saturated fat intake, and they showed that the groups that had the higher intakes of saturated fat actually had the lower mortality levels. And in their analysis, they looked at saturated fat intakes as high as it went, and there was no threshold beyond which increased saturated fat intake appeared to have a deleterious effect. If anything, the benefits continued to accrue as saturated fat intake increased. And this is certainly supported by the best randomized controlled trials that we have access to. The Women's Health Initiative study, which actually found that there was no adverse effects from saturated fat intake. They actually found an increased risk in heart attacks if you went on a low-fat diet. The group of females who were placed on low-fat diets had a 26% increased risk of cardiovascular events if they had pre-existing conditions. We've got the Sydney Diet Heart Study and the Minnesota study, both of which were retrospectively analysed simply because the original data wasn't published as it should have been, and these delayed analyses actually show impaired effects if you take saturated fats out of the diet. So the sum total of all the evidence is that saturated fat intake is safe, and there is no threshold beyond which saturated fat becomes deleterious.
Now, does that account for the fact that even in the obese, people that are clinically obese, that get obese, are they in a special population? Do we have to worry about those folks?
I don't believe we do. So one of the big problems with people getting worked up about saturated fat is that saturated fat in your circulation is very different to saturated fat in your diet. And we know that there are, and a lot of people will actually make this mistake. They'll say, well, I've got this data, it shows that saturated fat on this blood test is associated with insulin resistance and diabetes and what have you, so on and so forth. The problem is that a high saturated fat diet does not increase these saturated fats in your bloodstream. It actually reduces these levels of saturated fats. So while some people are absolutely correct in terms of saying, yes, well, it looks like saturated fats cause problems with regards to my health, that's only in the bloodstream, not in the diet.
Clearly, we see that, excess carbohydrate consumption, particularly refined processed carbohydrates, increase liver fat, triglyceride levels. And then we see that the liver is under the influence of things like insulin, and where we have these saturated fats and other fats that are liberated into the circulatory system. What is the thought on protein? Maybe excess protein being a driver. Does protein have any role in serum lipids?
Well, we often actually see significant elevations in serum lipids in conditions, as you know, called glomerulonephrosis, where you have a pathology of the kidneys, where you actually leak these proteins through the urine, you lose proteins. And this actually has a significant deleterious effect on serum lipids. So in actual fact, it appears the reverse is true. Loss of protein excessively leads to poor lipid profiles. High protein intake, I haven't seen any research that correlates that with any adverse changes on lipid profiles. And in actual fact, high protein intake is advantageous for multiple reasons. And people's fear of protein being converted into sugar is an irrational fear, simply because this process of gluconeogenesis, where we can take certain products and some of these amino acids and turn it into sugar, this is a demand-driven process and not a supply-driven process. Just because you have more ingredient that can be turned into sugar doesn't mean it will be turned into sugar. The body will only produce glucose if and when it needs to. So just by having a lot more circulating amino acids doesn't mean you're going to have an incredibly high blood sugar level. It just doesn't work like that. The body's smarter. So we have to remember it is a demand-driven process, gluconeogenesis, and not a supply-driven process.
Yeah, I had Ben Bickman on the other day, and I probably should have asked him this, because someone is, let's say they have type 2 diabetes pathophysiology. They go on a low-carb diet, and they lower their insulin, they lower their their glucose, both fasting and postprandial numbers. They clinically lose weight. They improve things. Does that fundamental pathophysiology still exist? Is this a genetic thing? Is this a basic cellular thing that do we know what that is? Can we get rid of that? Is it something that is always going to be there for that person? Can you? Yes.
In terms of the insulin resistance or the high blood sugar level, or?
Well, I mean high blood sugar. Sure, we can fix, but the insulin resistance,
Oh no, we can absolutely reverse that. So this argument about whether people on low carb diets have actually truly fixed their diabetes or whether it's diet controlled, this is absolutely disproven. I've literally got hundreds of craft tests where we actually subject people to glucose loads and we prove that their ability to handle sugar loads without seriously elevated blood sugars and without massive spikes in their insulin is actually correctable. Now, this is not everybody, but certainly in a substantial proportion. The problem is that if you have type 2 diabetes bad enough for long enough, that will end up damaging your pancreas, the beta islet cells in the pancreas that actually secrete the insulin. And there's multiple mechanisms. One of the major ones of which is what we call advanced glycated end products. So these advanced glycated end products are actually when you have sugar attaching to a protein, and it actually damages that protein. So the very process of type 2 diabetes in itself will initially lead to an escalation of insulin levels through insulin resistance. And then it will paradoxically destroy your body's ability to increase insulin levels because it's destroying your islet cells in the pancreas. So if you've destroyed all your islet cells, then you don't have that capacity for reversibility. But if you're just at the insulin resistant stage where you've still got massively high insulin levels, then that's very fixable.
Do you find that as many of the plant-based advocates, they will say that intracellular lipid deposition is a significant factor in insulin resistance? What are your thoughts on that particular?
I'm not familiar with that argument. Are they talking about hepatocyte intracellular or what cells in particular?
I think they're talking about ceramide formation.
Ceramide, the retinol binding protein 4, all that pathway.
From palmitate and other long chain saturated fats,
Sure.
lipids and that sort of thing.
Sure. Well, they may actually have a point, because when we actually have a look at serum palmitate levels and things like that, that probably reflect intracellular levels. That probably does have a role in the pathophysiology of insulin resistance. But here's the thing. A high saturated fat diet actually leads to reductions in palmitate levels. So while they might have an element, a grain of truth there, they're actually missing the point that a high carb plant-based diet would likely lead to that getting worse. In actual fact, they're making our argument for us, if that's what they're saying.
Can you fix insulin resistance with a low-fat diet?
I don't have any clinical experience with prescribing low-fat diets. I've not read any convincing evidence. Certainly, if you calorically restrict people, then you can have certain effects, but that's not sustainable. So the point is, on a non-calorically deficient diet that's sustainable in the long term, can a low-fat diet work? I'd have to say no. In the short term, if you wanted to put somebody in a caloric restriction, you can have somebody on a ketogenic diet that's low fat simply because they've just got a deficit of intake, and that will lead to benefits. You can't sustain that, and it's not practical. So in effect, you'd have to say practically no.
I mean, a lot of people here probably tried that route, and that's why they're here. There's a question from Patricia. She says, if someone has very low iron, and that's a common problem, particularly in women, that's causing weight loss problems, do they need to get an infusion, or can they eat a high iron diet? What are your thoughts?
So it really depends. So when we have a look at iron deficiency, this is a huge problem. We have to put it in categories. You're a doctor, you know exactly what it is. So first of all, we ask, what are you eating? Have you got enough heme iron in the diet? Is it just a problem of deficient intake? And for a lot of females where, fat's been vilified, their whole life, and they're listening to health messages, a deficient intake of iron is certainly plausible. Then we come to the possibility that you might be having a sufficient intake of iron, but your body just can't absorb it. And this is the kind of problem we might see in people with celiac disease or inflammatory bowel diseases, where this increase in inflammation and several other factors will actually prevent their body from absorbing the iron. And then the third factor may be that you are eating enough iron, you're absorbing the iron, but you're losing it excess. So I saw a patient recently who had a long history of bleeding hemorrhoids, who was profoundly iron deficient. Most commonly, this is excessive menstrual blood loss in females, or it's recurrent pregnancies, because every time you give birth, you donate some of your red blood cells to the baby, you lose a certain amount of blood during the labor process. And recurrent pregnancy in quick succession on a standard Western diet will predictably lead to iron or relative iron deficiency in a lot of females. So if we factor in all of those, it could be you're not absorbing it, it could be you're not eating it in the first place, or excessive blood loss means that you're losing it through another route. So whether or not everybody needs to take iron, if you have this malabsorption issue, then you can take as much oral supplementation as you want. It's not going to do dork. The simple fact is you need to either correct the problem of absorption, the inflammation in the gut, or the issue, the parasitic infection, whatever it is causing a limitation of absorption, you need to fix that. Or the other alternative is you get it through a vein. What we're now using a formulation we call in Australia Ferinject, which is actually much safer in terms of risk of anaphylaxis than the previous formulations that we used. And it's actually quite easy. The biggest risk factor is that you get a tattoo, an iron tattoo on the skin that can actually last for years and years. But aside from that being the most common complication, it's a relatively safe and very effective. Most of my patients, if they have an absolute iron deficiency and we opt to go down that route, they'll report that they get improvements. Within 1 to 2 weeks, they start to feel significantly better. But then there's a whole nother kettle of fish when we talk about something we call functional iron deficiency, which is a state of inflammation that prevents your body from accessing iron that you've already got. It's basically starvation in a land of plenty. And if you have functional iron deficiency, one, it's much harder to diagnose. You need an astute clinician. And number two, the only solution is to treat the inflammation. You cannot just stuff more iron into the system, because whatever iron you stuff into the system will just be locked away in storage, the same as your existing iron.
Yeah, this is from Carl, and he wants to talk a little more deeper in the thought of beta cell failure, particularly. So, I mean, I think it's important to point out, Carl's asking why and how are the beta cells being destroyed by insulin resistance and hyperinsulinemia. And I think it's important to point out, we have something called like LADA, or the type 1 diabetes, which is an autoimmune thing. And then we have this phenomenon where chronic hyperglycemia, chronic type 2 diabetes, which I don't believe is an autoimmune issue, but still results in islet cell burnout. Can you discuss the mechanism by which islets, beta cells in the islets of Langerhans are ultimately...
Well, let's start with type 1 diabetes. So this is, your immune system's job is to fight pathogens, so external pathogens. And sometimes it goes rogue. And rather than attacking a pathogen that it should have a specific affinity for, it will misidentify a cell of your own body and go to town. And in type 1 diabetics, they've got these antibodies circulating. Their immune system is generating these guided missiles, for want of a better term, that are actually attacking their own cells in their pancreas that will produce insulin. Now, as you mentioned, we've got this LADA, which is latent autoimmune diabetes of adulthood, and probably there's at least 10% of people with diabetes who are diagnosed over the age of 40 who actually have an autoimmune component. And in actual fact, when I'm testing for it, there's a couple of antibodies we test for, islet cell antibodies, glutamic acid decarboxylase, and there's a few other things, zinc transporters, so on and so forth. When we test for these, I'm seeing antibodies against this even in people with normal blood sugar levels, but they've just got an autoimmune tendency, I see, from other antibodies. So, and we know if you've got one autoimmune disease, it's a bit like Pokemon. Once you've got one, you've got to get them all. Misery loves company. The same pathological process that leads to an autoimmune disease against one tissue can lead to an autoimmune disease against another tissue. So that's why autoimmune diseases come in what we call clusters. And when I'm assessing people, I'm actually constantly surprised at the number of people with autoimmune attacks against their pancreas, even in otherwise ostensibly healthy people with normal glucose levels. And certainly this is an iceberg, an unforeseen problem where people who are older are having these autoimmune damages. And this is a problem because we assume that if you're over 40, or even if you're over 20, if you have diabetes, it's your own fault. It's type 2 induced. It's insulin resistance because of diet, so on and so forth. It's de novo lipogenesis, excess carbohydrate consumption, you know, and we ignore this immune problem. And I think the sooner we identify this immune problem, it's really important, because we know there's certain dietary factors such as lectin elimination that can actually be potentially very beneficial and will potentially save somebody from actually being on a lifelong insulin dose. In terms of sugar control, we know that there's very good evidence that advanced glycated end products, simply from sustained elevations in blood glucose level, will actually lead to a damage of these beta islet cells, and that's certainly something we're very familiar with and we see a lot of. And probably one other thing that a lot of people aren't aware of is that you can actually have antibodies against insulin itself and insulin receptors itself. So I'm seeing a young lady at the moment, a pediatric patient, who had an increase in her insulin requirements that basically increased by 6 times in the period of 3 months. And there is no way that that is normal. And unfortunately, it's difficult to test for. We have no assays for this in Australia. We actually have to send it off to the United Kingdom to actually have these insulin antibodies and insulin receptor antibody assays performed. But it's actually, again, very revealing, because we know it's autoimmune. We see somebody with seriously increasing insulin levels, and we usually blame insulin resistance, when in actual fact it is insulin resistance, but it's of an autoimmune cause. And the treatment takes on a very different route.
Let me see if someone has something else they want to add to that. I know somebody wanted to go back. I want to, what do you think about incretin hormones, GLP-1, GIP, and the role of insulin resistance in, development of diabetes? We see that, I've done quite a bit of reading here, and one of the interesting things I saw, that glucose, in the blood is less potent at stimulating insulin than glucose is in the GI tract, due to the effects of,
Oh, that's absolutely true. Absolutely, 100% true. And this is what I term food syntax. So for the same quantity of macronutrient composition, we can have a very different impact on blood sugar levels and insulin levels. And one of the interesting things has been shown that this simple test for solubility of a food in water, which basically says, well, how quickly it'll be dissolved in the gastrointestinal tract, is actually very predictive of the insulin response. The idea being that when you're talking about GIP and GLP and these kind of things, is that earlier in the gastrointestinal tract, we tend to have a pro-insulin releasing effect. Whereas if the food stuff can migrate it all its way through to the end of the gastrointestinal tract or later on, it has an insulin inhibiting effect. So if we're having foods that are rapidly soluble and rapidly digested, that means we get this proximal stimulation where we get a big spike of insulin, and they're not able to get down further in the gastrointestinal tract where they put a brake to the process. And this is where ultra-processed foods, because by virtue of the fact they're rapidly digestible and absorbable, cause a disproportionate spike in insulin levels. And I think this whole incretin thing is poorly understood by most doctors. Our traditional teaching is that it's blood glucose levels that cause a spike in insulin levels. And to a degree, that is true. But by far, it's certainly not the major impact. And these other factors, the incretins, are certainly poorly understood. And the advice that you would come out of it is to say, don't have ultra-processed foods. So all processed foods will be deleterious from an incretin perspective.
Yeah, I've had, just for various reasons, I've had quite an interest in that and seeing what stimulates this. And we've got that, the 2 phases of insulin response, the one that occurs within a few minutes, and 30 minutes later or so, we get the second response. And the GLP is, from the L cells down in the ileum, but it can be influenced by GIP and the sweet taste receptor in the mouth, and there are neuroendocrine inputs into this. And so it's a very complicated system. but it seems to be one of the more powerful drivers of what's going on with this insulin. So it's really a lot about food. And we do know that the islet cells are surrounded by blood vessels, and they have glucose sensors and other nutrient sensors, which does seem to drive things. But again, it's all mediated by cyclic AMP, which probably has to do with changes through these different transporters. But let's shift. That's all the crazy time. Probably most people want to talk about. I find it interesting. Phlebotomy for ferritin, and what's your target goal for ferritin? And if you have hemochromatosis, you don't. Do you believe that there's an optimal ferritin level? I know we talked about maybe ferritin may not even be the best thing to be measuring. What are your thoughts?
Well, this is confounded because ferritin is what we call an acute phase reactant. Basically, when your body gets inflamed, it assumes it's infected because that's how we've evolved. We've only ever really evolved with inflammation being representative of an infection. And the problem is now inflammation can be reflective of an autoimmune disease. So our body's response is now aberrant. But if your body says, I'm inflamed, the response is, if I have an infection, these infections need iron to thrive just as much as the human body does. If we can lock these iron stores away, we'll prevent them from actually, we'll make it easier to eradicate this infection. And that's why what happens if you have iron coming into the body and you're inflamed, you'll just lock this iron into ferritin molecules, which will continue to increase and increase and increase. So you can end up with a situation where you've got very, very high levels of iron, but you cannot use it. So that's why iron is what we call an acute phase reactant. It's reflective of an inflammatory state. So in people who have very high levels of ferritin, it matters whether they're inflamed or not, because if they're very inflamed, and you would have, I know you've seen this a number of times yourself, Sean, people who have had high ferritin levels indicative of excess iron stores and tentative or presumptive diagnosis of hemochromatosis, when they go on a carnivore diet, which while it increases the supply of iron, it reduces the inflammatory stimulus, their ferritin levels will actually fall. So it's very difficult to put an arbitrary level on something like ferritin and say it should be this, it should not be this, because without knowing what the inflammation level is, you're running blind. But as a rough rule of thumb, there is a lot of debate in the literature, in the hematology literature. And as a general rule, if it's over 1,000, you probably should have it lower. If it's over 500, you could probably make an argument to have it lower. Some people actually want to drain it back down to theoretically what we call normal levels, below 300, below 200. The problem is if you have inflammation at the same period of time, then you might bring somebody's ferritin down to 200, but because they're inflamed, that they're actually relatively iron deficient because they can't use it, and they'll end up with symptoms of iron deficiency. And you would know that when we see patients with hemochromatosis who have been subject to venesection, or leech therapy, to a level where they're actually able to, they get it down here, they feel lousy. So it's a problem of, I don't believe you can have a threshold if you're inflamed, and if you're not inflamed, I personally think about 500 is a reasonable target to shoot for.
Yeah, that's much higher than other people. I mean, there's people out there that think it has to be super low. And I think, again, this is probably context dependent, like most
Well, the
things.
problem is getting it super low, people feel lousy. And what I didn't mention is there are other things. We know it's a pro-oxidant type molecule, and there are other things we can do to reduce oxidative stress. And there's at least some early animal data showing that things like melatonin, which is a potent intracellular antioxidant, can actually benefit and reduce the deleterious side effects of hemochromatosis, at least in the murine model.
All right, Paul. I don't see a question, so I'm going to bring up a topic that is always, and somebody commented they loved your talk on LDL cholesterol. So can you outline, is LDL killing us? Is there any reason why we would be concerned with high LDL cholesterol in any context?
Yes, if it's damaged LDL. So we can have different populations of LDL. It can be a normal physiological population, what we call healthy LDL, large, fluffy, or it can be glycated or oxidized or damaged, in which case it becomes atherogenic. So, and I think it's important to know, I could care less how much healthy LDL I have, but I sure as heck don't want any of this oxidized atherogenic LDL. And as a cross-reference to our previous topic on hemochromatosis, we find that people, if they are having excess oxidizing stress from hemochromatosis, very high ferritin levels, this will be manifested in their LDL subfraction when we run a lipid electrophoresis and we separate it out within a gel to see what their separate peaks are in LDL. They will have a lot of crappy small dense LDL, and that's something that we can actually improve with their diet. And when I see it go from this crappy pattern with lots of peaks down to a smooth homogeneous peak, then I'm saying I could care less what your LDL is. So certainly LDL can be problematic. So LDL particles is actually a different concept to total LDL, because what actually happens if you have a lot of this small dense crap, you'll end up with a lot of particles that are not able to be taken up by the LDL receptor in the liver, and they don't have anywhere else to go, and they through a variety of mechanisms, which, and interestingly, one of these is, I'm not sure if you're familiar with Vladimir Subotin, he developed a theory about the way these pathogenic LDL particles then enter the atheromatous deposits, and he thought it was through peripheral blood vessels, vasa vasorum, and I actually think he's probably correct, and we're currently working on a paper, and Ivor Cummings is involved in that at the moment, but that's a bit of an aside. But certainly, if you have bad LDL, that is bad. If you have healthy LDL, I could care less. It could be as high as a rainbow.
Is there, how do we easily, can we easily measure bad LDL? And I get, you know, again, that's going to be oxidized or glycated LDL. Can we assume that based on, you know, weight from, you know, or is there a way to, like, there's a normal test, you know, I mean, it seems like we have to get a specialized test to measure oxidized LDL. Is that true in Australia? And I'm sure other
Well, yeah, yes and no. So you can get a special test to have a look at oxidized LDL, and there's no way of specifically looking at it without doing a specific test. You can either do specific antibodies or look at this subfraction, the lipid electrophoresis. Having said that, for most people, it's totally unnecessary, because when we have a look at the associational data, particularly the triglyceride to HDL ratio, we can reliably predict whether you have a healthy or a poor LDL. And for my money, if you've got low trigs, high HDLs, you're best spending that money on a massage.
Awesome. Okay, so Lark is asking about bone density. She said she was on a low-carb ketogenic diet for 4 years, did not see any significant improvement based on DEXA scans. Have you seen any clinical improvements with a carnivorous diet, which is, you know, in my view, going to be a higher protein diet?
Just yesterday, had two patients come in and say that they've fixed their osteoporosis. And funnily enough, I think they mustn't watch my lectures because they came in wanting to know why. So in the most recent lecture I did on ketogenic nutrition in athletes, we actually talk about the evidence that you can actually reverse osteoporosis. This is not new. It was a randomized control trial back in 2002 by Dawson and Hughes, who actually did a study where they gave people vitamin D and I think it was calcium citrate or placebo. And then they did something smart. They placed these subjects, they separated them out into tertiles of protein intake. And then they monitored them for 3 years with their bone density on DEXA scanning. And what they found is that the group with the highest protein intake actually reversed the declines in bone mineral density. The group with the lowest protein intake, they actually had losses of bone mineral density. So it was shown to be protein dependent. And this makes sense because 40% of the dry weight of bone is actually protein. Protein is basically, or bone is a protein scaffolding with, you know, some of these minerals just plugged into it. So if you think about it, your body will break down bone when it needs access to calcium. So if we give you high doses of calcium and vitamin D, that will potentially reduce your body's requirement to break bone down. And that's what we see when we supplement people with vitamin D and calcium. It sort of puts a hold on the process of the bones getting weaker, but it doesn't reverse it. And that also makes sense because if you need to rebuild it again, or you're only putting in calcium as the main ingredient, you're missing the vital ingredient of protein. To actually construct something, you need all the ingredients. So once we put enough protein in, then the body's able to rebuild the bone. And it makes perfect sense. This has been a lifelong myth. I remember in the 1990s being taught that by the time you were 20, you had all the bone you were ever going to get, and it was all downhill from there. Well, we know that's now false. If you have enough protein, you can actually restore bone mineral density.
Yeah, Belinda, I talked about that before. Okay. Shifting over to homocysteine, are you seeing problems with homocysteine in general populations? Does it reflect, is it conditional? I'm ad-libbing some additional questions in here just because I like to, but what are you seeing with patients? Do you find people in a carnivore diet having lower homocysteine or higher, rather higher homocysteine?
Absolutely. Homocysteine is misunderstood and misinterpreted. So everybody gets so worked up about B12 and folate, and you need to be on methylated this and, you know, my homeopath and all of this kind of stuff. Elevated homocysteine is basically a reflection of nutrient malabsorption. So, and we can be more precise about it. Is it B2, is it B6, is it B12, is it folate, what have you, so on and so forth. It is basically, I believe, a reflection of autoimmune regulation in the gut, causing inflammation, impairing nutrient absorption. My target, so in the literature, there's a very clear cutoff of saying if it's over 9, it is problematic. If you have a look at the all-cause mortality curves, they will actually show that, you know, it actually, anything up to 12, 14, the risk of dying over the next 5 years is significantly multiplied, almost exponentially. So this is a hugely important factor in health. I believe that we probably even need a tighter cutoff, and I would actually like it to be under 8 in my patients based on the data that I'm seeing in clinic. And I reliably see homocysteine reduce in people when they eliminate toxic plant foods, even in the complete absence of specific supplementation with B group or methylated vitamins.
Okay, let me just shift gears again. This is about postmenopausal women, which always seem to be just getting the short end of the stick on a lot of things, unfortunately. But talking about low testosterone levels and leading to, does it lead to a weight loss stall perhaps? And how can they raise their testosterone levels outside of weightlifting, maybe eating a carnivore diet? What other things can postmenopausal do to raise testosterone? Are there supplements, or obviously there's...
Well, we have to come up to the simple question, Sean. What's testosterone made of? What are all sex hormones made of?
Right. So they've got a
cholesterol.
Right. Sure.
You know, so I think that the first thing is to make sure you're having an adequate intake of cholesterol. If you don't give the body the building blocks to make something, it can't possibly make it. Just in terms of hormones, that's something that in particular with females, I think is terribly misunderstood. In particular, because we have these implanons, we have Mirenas, which are progesterone-eluting IUDs, we have the oral contraceptive pill, we have patches, we have pessaries, we have all these hormonal treatments, hormone replacement therapy. We have issues with, you know, do you have a uterus or not? Do you need estrogen, or do you need estrogen plus progesterone? And the big problem is that most of these female exogenous hormones actually cause insulin resistance. The highest levels of insulin I've seen, and when we're doing craft tests, I've seen them go over 500 and 600, have always been on females on exogenous hormone treatment, either hormone replacement therapy or some other type of hormone. And there's a very, very interesting thing that we can do. The reason this is important is because we can give hormones in a way that doesn't induce this insulin resistance. Because if you take an estrogen, for instance, orally, and it has to get processed by the liver, that hepatic processing generates insulin resistance. If you take that same hormone, what we call parentally, so it might be as a pessary, it might be as a patch, it might be as a cream, then it actually doesn't have that same degree. So in female athletes, this is particularly important because of effects on the bone. So we certainly know that there's case reports of, you know, in poor bone effects and, you know, catastrophic failures of bone in females on certain hormones, but they're sort of relegated to idiosyncratic, you know, unpredictable effects. But we definitely know that insulin-like growth factor 1 is an important molecule involved in maintaining bone health. And if you take oral estrogen, IGF-1 goes down, insulin resistance goes up. Whereas if you take the same estrogen through another route, it doesn't have that effect on IGF-1. It doesn't have that effect on insulin resistance. So insofar as female hormone therapy goes, I think you need to have, if you're a patient, you need to have a good conversation with a very good gynecologist who's prepared to entertain this differential effect of route of administration of female hormones. So yeah.
This is somebody, I think we kind of touched on this, but just to be clear, in case we didn't clear it, but David's saying, can you reduce your ferritin levels on a carnivore diet? Some doctors say you can't do that. And, you know.
Well, I've seen ferritin levels reduce on a carnivore diet. You've seen ferritin levels reduce on a carnivore diet. You know, some people believe in unicorns, you can't help them.
Yeah, so that clearly is occurring, whether or not we fully understand the mechanism, you know.
It's an inflammatory mechanism.
Yeah. I mean, I do think that. I think there's also, you know, when I look at insulin, the way it interacts with hepcidin, I think that's also, I think we get a reduction in absorption, you know. I mean, you know, I think, yeah, most of the regulation of iron is through the absorptive route. We can't really excrete it as well. So it has to be regulated at the, you know, the level.
And hepcidin is the key molecule because that relates with this ferritin. Unfortunately, at least in Australia, I've actually tried to get hepcidin assays. We just can't get it. So I have to use C-reactive protein or erythrocyte sedimentation rate as a proxy for what we think the hepcidin will be doing.
Yeah, somebody's just clarifying on testosterone, sublingual lotion instead of a pellet. Is that, I don't know if there's a preferred route for women with menopausal.
As a sports doctor, I simply can't prescribe testosterone ever just because I'm dealing with Olympic athletes, and that would not look good on my prescriber history because it would cast a pall over any of my patients. So I'll probably stay away from any comments.
So there's pros and cons, and I've never prescribed testosterone. I don't take it. I had to write for one steroid once in my entire career when I was working as an intern in a pediatric burn unit, and the attending physician told me write a a prescription for this, you know, oxandrolone or something like that. That was it. It was the only time I've ever written a prescription for a steroid. It was a poor burned up kid. So I don't have a lot of clinical experience with that one.
And the funny thing is, I have a lot of people come in and maybe inquiring about side effects or benefits of certain things. And it seems to be that if they want something, they will get it in the community. If they come in asking for prescriptions for things like raloxifene that will help prevent some of the side effects of these substances. But in general, they seem to have no trouble getting them outside of the medical setting anyways.
All right, well, let's talk a little bit about, thyroid hormone for fun. What are your thoughts on carnivore diet, low carb diets in general, saying that it tanks your thyroid? You're going to end up with a thyroid deficiency or cortisol, stressed out by cortisol levels. What are your thoughts on those two concepts?
Well, let's go on thyroid to start with. So first of all, I was chatting to another doctor recently, and I made the comment that a lot of the general public didn't understand how to interpret what we call thyroid stimulating hormone. And I was absolutely taken aback when this doctor suggested to me that multiple of our colleagues actually don't know how to correctly interpret thyroid stimulating hormone, because this is sort of something that somebody in first week of medical school should get. And the key thing here is that when we see thyroid stimulating hormone, the way the negative feedback works is that a lower number is actually better. And a lot of people assume that a higher number must be better. And this simple error has, I personally believe, led to a lot of people assuming that it, as you said, it tanks your thyroid levels. So that's the first misunderstanding, is that a low TSH is actually indicative of more active thyroid function than high TSH. And number two, the very concept of resistance. So when we're talking about insulin resistance, we actually know that lower insulin levels are associated with improved sensitivity and improved function. And the same also holds for thyroid. If we're looking at T3 levels, or T4 or what have you, we know that a lower level of this thyroid hormone, if that's able to exert the same benefit, the same impact, will then be associated with improved thyroid sensitivity. And Steve Finney's studies very clearly show this evidence of improved thyroid sensitivity without any effect on basal metabolic rate or any of the other functions controlled for by the thyroid. So this whole thing that, these ketogenic low carb carnivorous diets can tank thyroid function is factually and fundamentally wrong. Another point I'd like to make is that the most common autoimmune disease that I diagnose is actually called Hashimoto's thyroiditis, which is basically an attack of the immune system on the thyroid gland here in your neck. And we often will have side effects resulting from this autoimmune attack long before you'll actually get significant changes in your TSH, your T3, your T4, your reverse T3. And I think that as a part of any comprehensive assessment for thyroid function, you should always do thyroid antibodies.
Do we have a good way to assess for not only thyroid receptor, either density or sensitivity outside of biopsy? I mean, and that would go for insulin receptors and androgen receptors. And I mean, or is it all, are we down to only biopsies, or do we have good proxy serology that can kind of guide us on what's going on at the receptor level? Or is it just all by indirect observation?
I think this is all by assumption. I haven't read any research on receptor density in the thyroid, but one would assume that if you're maintaining your thyroid functionality as opposed with your resting metabolic rate and so on and so forth, and if your thyroid levels are decreasing and your TSH is still holding out or even reducing, then that would indicate thyroid function, and I think that would be reliable.
Yeah, I mean, we have, clearly we see a lot of these receptors where they're at the level of the nucleolus or on the cellular membrane. They are constantly turning over and being expressed and underexpressed and overexpressed, depending on the clinical situation. I think it's a constant flux, and many people don't understand that. They think that the lab value of what's in the serum is a static, marker of what's going on, and we realize it's more dynamic than that.
Yeah.
That's just a comment, Paul. I don't expect you don't have to comment, but there's a person here that says they've got a friend who is almost vegan, little eggs and fish, gags, and she tries to eat meat, doesn't want to eat animals. She's chronic digestive issues, bloated stomach, no muscles in her arms, sunken eyes. What advice should I give her? She also has poor bone health, damage to ribs getting into her car. I don't know. Do you have any advice for people trying to convert vegans into?
You'll probably appreciate this as much as anybody, Sean. I actually see a disproportionate amount of vegans in my clinic, and God only knows why. They're often in for a shock. The big problem is, I ask people, why are you vegan? The people who say I'm vegan for my health, they are absolutely the easiest, because it's very easy to prove objectively with lab testing and examination, investigation, so on and so forth, that their diet is hurting their health. No problem, we fix that. It's all a matter of education. The people who are ethical vegans, I think, are the next easiest to fix, because that is also a matter of education. It takes a lot longer. I usually recommend Lee Keith's book. And I usually start off with something like, are you open to new ideas? And everybody wants to say, I'm not closed-minded. Sure, yes, of course I am, doctor. Of course, it's like, great, here's a book. It's called The Vegetarian Myth. It is a meticulously referenced tome, and I think it strikes a very sympathetic balance between the psychological rationale for commencing a vegan or a vegetarian diet, and while still having a very dispassionate view of the science. It is all evidence-based. And multiple patients I've had have actually read that and sort of come around. The hardest group of people are these who seem to have a psychological aversion, whether it's through this continued indoctrination against meat or what have you, and they describe this incredibly visceral response to meat consumption. It makes me gag. I physically vomit. Now, I personally think that this is evidence of probably a bit of psychological issue as well. And I think that it is able to be overcome, but it is certainly difficult. And those consults go for a long time. And we usually talk about graded introductions. And I find that approaching it from a belief perspective and an ethical perspective probably seems to be most helpful, because what a lot of people don't realize is there's probably these underlying beliefs that is being manifested in these overt physical behaviors. But it is difficult, and I would recommend Lee Keith's book as a first port of call on the understanding that it is relatively sympathetic. Now, for some people who have these health problems who are never going to stop being vegan or vegetarian, a book like Stephen Gundry's Plant Paradox, I think, is reasonable because it does address some of the toxicities of plant-based foods. And while being completely and utterly biased against meat and animal products, I think it addresses important concepts that if you're going to continue consuming these foods, there are ways that you can make them safe. We can seed, we can ferment, we can cook them on high temperature, moist temperature for a long period of time, and potentially we can take these supplements which will actually bind to the damaging lectins before they get digested and prevent or at least reduce some of their deleterious effects. But at the end of the day, some people, this is almost a religious doctrine, and some people are just not going to be convinced, and we just have to accept that we can't fix the woes of the world on our own.
All right, this is a question from Michelle, and then I want to bring it back to autoimmune and gut health. But Michelle's just asking a question: if someone's got our osteoarthritis, should they limit weightlifting if they're experiencing no pain, lifting slowly with good form?
So I'd say no. So we know that osteoarthritis. So the way osteoarthritis damages is if you grind a joint, you can actually have little fragments of cartilage, this smooth cartilage. So let's go back to what cartilage is. So if you get a soup bone or a dog bone, on the end of the bone, you've got this smooth, shiny surface. That's articular cartilage. That's super smooth, super hard. So two sheets of articular cartilage sliding against each other have less friction than two sheets of wet ice. This is pretty good stuff we're talking about. If that protective surface gets ground down, that's effectively the diagnosis of osteoarthritis. And if you break some of these molecules away, these little particles, they will actually inflame the inside of the joint in the same way that we traditionally think that gout will, and you'll often get a delayed inflammatory response. So that's, if people are wanting to know, is an exercise bad for them? It's not just whether you get pain during the exercise, but it's whether you get a delayed inflammatory response that will be indicative of having some of this articular cartilage debris coming off. And that usually means you're feeling worse or sorer the next day. So I'll actually use your morning symptoms waking the next day to titrate your exercise levels. And it might be that you reduce the intensity or you reduce the volume or so on and so forth. And in some athletes, what I've actually done when I've been trying to talk them into retirement, like I'll go, these are professional athletes getting paid good money and they really have no other career options. So we tend to push them a little bit harder than we otherwise would. I'll actually stick a needle into the joint after the day after the game and get the fluid, and then we'll put it in the centrifuge and spin it down. And we can actually see these cartilage fragments actually collecting at the bottom. And when we send it to the lab, they'll say, yep, that's definitely articular cartilage. If you're in that situation and exercise is doing that to your joint, you should stop that exercise. But in general, you might have resilient articular cartilage that is not being broken down by the exercise. And this is where the concept of mechanotherapy comes in. And basically mechanotherapy says that when we stress a tissue, the tissue will actually increase in strength so long as we don't overload it. So if we take mechanical force away from a tissue, we send people into space, they come back, they have osteoporosis, they have weak bones, and we take them out of the shuttle in a wheelbarrow basically because their tissues have weakened. But if we have controlled amount of exercise, controlled amount of force on the tissue, it will strengthen. And articular cartilage is exactly the same. So we have a cell called a chondrocyte, which is effectively the main cell in the cartilage. And around that, the periphery, we have something called an extracellular matrix. And the extracellular matrix is what actually confers the mechanical properties to that connective tissue. And if we put on regular force at the right threshold that's not breaking it down but loading it, that extracellular matrix will get stronger and more resilient to compressive and shear forces. So if you are able to exercise and it doesn't hurt during the exercise and it doesn't hurt the next day, in effect, you are benefiting and strengthening your remaining articular cartilage. That is a good thing.
All right, good point. All right, so let's just on autoimmune disease. You are a fan of, well, we've had Chava Toth and Sophia Clemens are big on the PEG 400 test. They feel that gut permeability has a vital role, like Alessio Faisano out of Boston Children's, in the development of autoimmune disease and probably a whole host of other things that we show up with. And I know you've had some I mean, you test your patients for that. You monitor them. I think you use fecal calprotectin. What is the protocol? How do we manage? How do you manage autoimmune diseases? And with diet, with other things, how do you measure it? What are you doing with regard to those types of things?
A couple of key pillars. So let's get the simple ones out of the way. Good amount of exercise, good amount of safe sun exposure, and that's a whole conversation in itself, but it's got to be safe, but good amount of safe sun exposure. And there has to be a sufficient amount of sleep. And we're not talking 7 hours, we're talking 8 hours plus. Then it comes to things like personal care products. So you can have toothpaste with something like carrageenan in it, which is known to increase intestinal permeability and a bunch of these kind of things. So you have to look at what you're putting into your body, what you're putting onto your body. I've just seen shampoos that have wheat protein in them. If you had psoriasis and a dysfunctional skin barrier, that's going to be absorbed into your body. You're using this toothpaste with carrageenan, that's going to be a problem. Some soaps are going to be problematic. So we know that lipstick is often contaminated with gluten. Well, guess what happens to your risk of the autoimmune disease lupus in females who use lipstick? It's near doubled. So we have to be very careful about what we put on our bodies and in our bodies. And then we come to food. And as a really simple summary, certain foods, mostly having plant-based lectins, have the potential to exacerbate or trigger autoimmune disease. So it really comes down to either an absolute elimination of these plant-based lectins or a trial elimination of these plant-based lectins. And then to further muddy the waters a little bit, there are some arguments you can make against certain dairy and egg whites. And for some people, you just really need to do elimination-based diets and then trial-graded reintroductions. And you can pretty quickly work out what diet they function best on.
Somebody's saying, somebody from Australia, do you have a toothpaste of choice in Australia? I have no idea what brand you have.
I don't do sponsorship. No, not really. Look at the label.
All right. Hey, what about, let me just, for the last couple of minutes here, can you comment on oxalates? There's a lot of concern in the carnivore community about oxalate dumping. We know that obviously oxalates are associated with renal stones. There's some people that will say they are responsible for much, much more than that. What are your thoughts on oxalates in general?
I think they can be, well, certainly we know renal stones are a big cause. I think oxalate arthropathy, certainly joint inflammation, which has previously been undiagnosed. We often will, if somebody has what we call episodic arthritis, for instance, we'll often stick a needle in, suck the fluid out, have a look under a microscope, and we'll say, oh, there's uric acid crystals, you have gout. Or we might say, well, you might have a condition called calcium pyrophosphate deposition disease. And traditionally, we've thought that this abbreviated CPPD is being very fastidious crystals that are hard to see under a microscope. The thing is, I suspect that when we're saying we're assuming these crystals are there, we just can't see them, I think we're probably looking for the wrong thing. And I think oxalate deposition is probably one of the major causes. And the literature coming out will certainly support the fact that oxalate arthropathy is far more widespread than conventional medical teaching would have you believe. And I actually work with a neurosurgeon, and we've just started, when we actually remove, say we're doing a spinal decompression or something, and take out a ligamentum flavum, a ligament in the spine that often causes compression of the spinal cord, we're sending it to the lab. And we're about to do a study where we often see CPPD in the past when we've looked for it specifically. So now we're going to start looking for oxalate crystals. And I think it'll be interesting to see what kind of, when we actually start looking for it, what we're going to find. I suspect we'll start seeing it more and more.
Yeah, it's one of those things where people, you hear it, you've never seen it because you've never looked for it. It's probably seen you more than in medicine. Well, Paul, thanks. We're at an hour. I really appreciate it. I think members do. This will be recorded, put it up on our YouTube channel, and I wish you the best. Thanks for being such a great resource. And, I have a lot of patients that see you that come here. We say, but Dr. Mason, my doctor, and they're pretty happy people. So you're doing a great job down there. So thanks again, Paul.
Thank you, Sean. Great to chat.
All right, guys, I'm going to shut this down, and I'll see some of you guys tomorrow. Everybody take care. Bye-bye now. See you guys. Thanks.